Hello everybody and welcome to the second lecture where we're going to talk about the medical chart review as a component of the physical therapy examination. And in the cardiopulmonary world, especially when you're treating patients inpatient, the medical chart review is incredibly important and can save you tons of time if done well. The experienced clinicians in this field say this is probably one of the greatest weaknesses of students and PTs early in their career. They do an inadequate chart review and they do unnecessary tests and assessments and miss things because of that. So we're just going to do a real brief run through on a good medical chart review, and hopefully it will draw attention to the aspects that are the most important in the cardiopulm world. So the overall goal is to get the pertinent information about your patient that will ultimately guide the choices that you make in your physical assessment and your treatment plan. So when you go into the chart, you first want to look at the date of the event, or the date when they were admitted, and their diagnosis. So let's talk first about this term diagnosis. So in the medical world, patients are often admitted with a primary diagnosis, kind of the reason that they got into the hospital in the first place. When you're looking at a chart review, you want to make sure you identify their primary diagnosis. But often, as they spend time in a hospital, they will acquire secondary diagnoses. And many times, it's the secondary diagnosis that is the reason for the PT referral. So you want to make sure you dig through some of the notes to make sure that you have the full clinical picture, because the collection of diagnoses that the patient might have will help you determine if therapy is even appropriate, what type of monitoring you're going to need to do during your therapy session to be safe and effective. The date is another one of those really important things that gives you a lot of information. First, knowing the date that they were admitted and given a diagnosis tells you how acute they are. And that will really impact your treatment. Now, the primary diagnosis date can usually be found in the patient's history, but to find the date of some of the secondary diagnosis, you may need to go into and review MD's progress notes to find exactly when those secondary diagnoses happened. Next, you want to take a look at the symptoms your patient is experiencing. What were they admitted with? Kind of what was the reason that they were brought into the hospital? But then definitely what type of symptoms have been occurring since they've been in the hospital. Gathering up the story of what the patient's experience has been. So it's good to keep in mind, what are we watching for here? What are some of the big players that you're going to be on high alert about? Well, you're definitely going to be looking for symptoms that might suggest they have any kind of cardiac involvement or potential pulmonary involvement. So when we talk about signs of cardiac involvement, we're really talking about evidence that they've been having any kind of symptoms of cardiac ischemia. So hopefully at this point, you might be slightly rolling your eyes and exhaling at the thought of going yet again over the signs and symptoms of cardiac ischemia. So you can fast forward if you're confident and see if your list matches. First thing that often comes with cardiac ischemia is symptoms typically occur above the waist. Okay, so if they're having foot pain, it's not very likely coming from the heart. Number two, big sign of cardiac ischemia is that the symptoms are exacerbated with exertion, right? When you increase cardiac demand is when you reveal symptoms of cardiac ischemia. And then the reverse of that would be that they're typically relieved with rest. All right, classic signs. What are we looking for to suggest that we have exceeded the myocardial oxygen supply with the demand that we've put on the heart? Obviously, chest pain and tightness is a big one. Pressure can go on that list. Shortness of breath, disproportionate to the activity. Palpitations. So palpitations is the word that's used to describe when patients have a sensation that their heart is racing or pounding or fluttering. So palpitations, we allow ourselves to assume that they're coming from the heart unless cardiac dysfunction is truly ruled out. Another big one here would be indigestion, very often mistaken. If you have exertion-induced indigestion, that is a very common finding of cardiac ischemia. Kind of goes with that. Similarly, you might describe a burning sensation. So these would be things that you would see in the chart that would give you the bells and the whistles that there might be some cardiac involvement. What were we looking for if we're looking for signs that they might have some kind of lung impairment or dysfunction? Well, shortness of breath, again, that gets both on the list. Dyspnea is oops, if I can spell dyspnea correctly, excuse me. Dyspnea is a huge sign of pulmonary involvement, and we're going to go into some great detail in our discussion section on dyspnea, but specifically dyspnea on exertion. Obviously, cough is a really big one here. Increased work of breathing would be a sign the pulmonary system is involved. And then if there is sputum production. Let me just put a quick plug in for the field of cardiopulmonary. If you loved exercise physiology, this could be the area of PT for you. We truly use exercise as an intervention to challenge these systems and record how the body responds. And this little guy right here is, I think, what scares a lot of people off. And it is, in proportion, a relatively small part of the field of cardiopulm. So if you just have an inkling that you might like this, don't be scared off. Give it a chance. I'm going to see if I can pull you to team cardiopulm by the time we're done. So looking for evidence of signs of cardiac involvement, pulmonary involvement, it's really important to know what their baseline symptoms are. Because when you come in and do physical therapy, you might be the first person on the medical team that challenges the cardiovascular and pulmonary systems. And changes in any of these symptoms can be very significant to the medical plan, to the patient's prognosis, to their discharge planning, all across the board. So you have to know what their normal is, what their kind of expected abnormal is, and what you might induce a change with exercise, for the better and for the worse. We'll see both happen with intervention. Okay, so past medical history, obviously looking for other medical problems, right, that they have in the background. That's not the reason they're diagnosed, but will certainly have an impact on therapy and how well they tolerate it. Obviously, orthopedic issues, neurological, psychological, integumentary can be layered on in the background of this primary and secondary diagnosis, but might have even the biggest impact on what they can do with you in therapy. In addition, I hope as you're going through anyone's medical chart that you're creating kind of just a running list of any risk factors they have for cardiovascular disease. Let's go through them quickly here because you should feel extremely comfortable with these at this point. The reason you want to be keeping track of risk factors for cardiovascular disease is the symptoms of cardiovascular disease may first present itself during your therapy session. You will see this will greatly impact the course of their time in the hospital. For patients who have more risk factors, will be treated more aggressively because the likelihood of negative outcomes is worse. Where the fewer risk factors there are, patients might be treated medically more conservatively. They might be opting for kind of a wait and see approach with fewer risk factors. So it paints a picture of your patient. It gives you reasons for further monitoring, to take any deviation from normal responses more seriously. It's good to know the risk profile of the patient you're dealing with. All right, so risk factors for cardiovascular disease. If you would like to, this would be a great time to just pause the video and write how many of these you know without me giving them to you. If you hit them all out of the park, you never have to study this again. These seeds have been planted, they took root, and the forest of knowledge has grown. If you're missing any, then you know exactly what to jam back into that head a little more. These are really important ones. Every patient practice should know the risk factors for cardiovascular disease. All right, if you're unpausing your video after making that detailed list, here's mine. All right, we got hypertension is a big player. Smoking, don't even get me started. Good thing we're not in person because I wouldn't be able to hold back. Dyslipidemia, abnormal blood lipids. We would have family history is a really big one. Let's see, what else goes on this list? Old age, so the older you are, the increase your risk. Obesity, central fat and the role that it has on cardiovascular profiles. Speaking of central fat, diabetes would go on this list. Being physically inactive is a risk factor. So I think so far, old age mate. I was going to say a couple of, I think we're all on modifiable, but that's not true. All right, so we got hypertension, smoking, dyslipidemia, family history, old age, obesity, diabetes, physical inactivity. Some people include this on their list. You may or may not have being male. There actually is an increased risk for men over women. And some people may include on this list stress as well. Those are kind of two that may or may not have made it to your list depending on kind of the source that you were using. Taking a look at their medications when you're looking through the chart. Medication is such a valuable tool. It gives you clues into underlying medical issues. This is really helpful in the outpatient setting when you don't have a full medical chart. If you have them bring in a list of their medications and, you know, during your subjective history, do you have any kind of medical issues? No. But then, do you have a medication list? They hand it over, they're on ACE inhibitors and a diuretic and a beta blocker and a statin. Obviously, they have some medical conditions going on, most likely something related to heart failure. So these collections of medications, the type of medications they're on, can give you a ton of information that might be missing if you're just relying on the patient's story. I will try to weave in as much little nuggets about medications as we go through the class, but I know I think you guys were in the first class of the Stronger Farm. I think you guys are my Stronger Farm crew. So hopefully you're going to feel even more confident about the meds. So good, relevant social history. Do you guys like my advanced Photoshop skills here? I added a little set of stairs to the house. Obviously, in any good social history question, what kind of home they're going back to. For cardiopulm, big things to keep in mind. Drug and alcohol abuse has a huge impact on the cardiopulmonary system. So making sure you're aware of any kind of habits, addictions, length of time that they might have been taking a certain drug or alcohol. So, like, for example, alcoholics have a really high rate of cardiomyopathies. Obviously, smoking has a high rate of COPD. Cocaine is associated with severe coronary artery spasming. So you can see some of these background information can kind of give you insight into some of the medical stuff going on. We will talk about this later on in the semester. We hit it a little bit in pathophys, but being aware of potential withdrawal symptoms, especially in an inpatient setting where they are no longer able to have access to drugs and alcohol, that can cause some serious cardiopulmonary issues as they go through withdrawal. So in a good chart review, you would review their clinical laboratory data. I'm going to do this in a whole separate lecture as kind of a pathophys review next. So I just wanted it in your notes here because it would be inaccurate to say you did a chart review without the clinical lab assessment, but we'll go into the details of that in the next lecture. So take a look at radiological studies, chest x-ray, CT scan. So read the radiology report. See what was found, look at the pictures yourself. You will train your eyes the more you look at these, that you can actually see the pathology, the anatomy, whatever is the thing you're looking for. Oftentimes in this world, cardiopulm, we look at serial radiographs to monitor progress of a disease. You can see the disease change over time. that can be really helpful to look at that serial imaging. Looking at the surgical reports is extremely important. So, first off, the longer the surgery took, like the more time they were under, the more their physiology was traumatized. So if you go back to basic pathophys, the traumatic response, the stress response, the cortisol, the longer they're under, you would expect a greater stress response. That was harder on their body. So that's first thing, looking at the length of time the surgery took. You need to know the surgical approach. Was it a laparoscopy approach, or was it a thoracotomy where they were cutting through big muscle groups and spreading the rib cage open? It will be critically important in your therapy to know how they got at the part of the body they did surgery on. You want to check if there were any complications during surgery. So some of the big bad ones is like perioperative MIs and strokes, knowing the full story of what happened during the surgery. We'll talk about the different types of lung surgeries, but if they go into the lung and they took lung tissue out, how much did they take out? Did they take a small section, a lobe, an entire lung? That will really impact their ability to do therapy. Cabbages, the number of grafts actually in a cabbage gives you a really important window into how severe they were, and maybe how physically limited they were before the surgery. Like if you never met them and you're meeting your patient post cabbage and they had a 4-vessel surgery, this is a much more advanced cardiac patient than someone who had a single. So some like these little pieces of the story give you a really rich background that can educate your choices, that can facilitate you being ready and being safe and being confident in the type of person you're about to walk into and challenge with exercise. The next thing you want to check is if they're being supported with oxygen therapy or any other respiratory treatments. So if they're using oxygen, what's the mode of delivery? So we will have labs with this, we'll have lectures on this, but nasal cannula is like the lowest level of support, just a little added, and then you go to more and more severe patients that require greater oxygen support. So face masks, ultimately patients might need ventilatory support with a tracheostomy collar, and there's many other ranges between. The more support they're getting from machines, the less able they are to obviously oxygenate themselves. So you're going to need to know the amount of oxygen being delivered. It's really helpful to correlate the story of their oxygen therapy over time with their arterial blood gases and their hemoglobin saturation. You might see a patient was kind of doing worse, put on a ventilator, and boom, they start doing much, much better because now they have the oxygen support. That can really fill in some of the details of a patient's story of how they were doing over the course of their stay. You can analyze the results of pulmonary function tests. That gives you both, you can get lung volumes and capacity, flow rates. Sometimes you can see PFTs over time, so you can see the progress, especially a lot of our pulmonary diseases get progressively worse over time, and so you can see the course of their disease over multiple hospital visits over time. Vital signs and EKG monitoring gives you information on the state of their cardiovascular system in real time. It's always, students sometimes are a little fearful of going into an ICU setting, and actually all three, well, this semester we'll probably have 2 lab instructors, but they both spend most of their time in the ICU, and they always say it's so strange to them because you have more immediate information on your patient's cardiovascular system when they have all the bells and whistles attached than to the patient who's just on the floor and doesn't even have telemetry. So using the monitor in an inpatient setting to enrich the feedback that your patient's body is giving you, so you know how hard you can push them, you know how they're tolerating therapy. should give you comfort, should give you confidence, to give them the appropriate dose of exercise to make the best impact on their life. We will go through the EKG in detail in this class. That gives you specific information about the heart rhythm. And EKG can be a really important feedback, signal from the heart that can tell you about previous MIs and hypertrophy and changes in impulse generation, blocks within the heart, that you may get much more specific into this if you went into a more advanced cardiopulmonary spot. If you're in a cardiac ICU floor, those things might become really, really important to you. The hospital course can provide really valuable information on your patient. Looking into the specific physician's notes and nurse's notes, when orders were made, can really fill in the colors of the full picture so you can see what was happening with your patient before you got to meet them. Looking at their nutritional support to determine how they're receiving the caloric needs to fuel their body. If patients have an NPO order, it means they have nothing but by mouth. A patient would be on nothing by mouth for complete bowel rest for one reason or another, but that's important to know what their order is. If they are receiving their nutritional intake, if it's going anywhere kind of through the digestive tract, so whether it's going through their nose or their stomach or their intestine, that's enteral, as it says in your notes. That is when they're receiving food and it does go through their digestive system in some way. So either through the nose, stomach, or intestine. So the nasogastric tube, these are great because they're named for where they go. NG, nasogastric, through the nose. And you can see it goes through the nose and all the way to the stomach. The nasoduodenal tells you exactly where the tube is going from the nose all the way into the site of the intestinal junction. Nasojejunal, the tube goes even further to bypass the stomach. So those are the three tubes that can get kind of threaded through the nose into the GI system. The fourth on your list is referring to a G-tube or a gastric tube. And that is a tube that goes through the abdominal wall into the stomach. So this is a picture of a peg, and you can see how it is implanted here. So it goes through the abdominal wall and then into the stomach. So you have a direct route into the stomach. So on the outside, you can see the stoma. Stoma is an artificial opening made into a hollow organ. So it could be the gut, it can be the trachea, and then it has the connector to the outside body. So that would be something to watch for, and anyone who's getting kind of long-term tube feeding would have a PEG tube. If they are receiving their nutrition intravenously and it's completely bypassing eating and digestion, they're getting parenteral nutritional intake. This is normally delivered into a large central vein. They might use this for partial nutrition if it's supporting their nutritional intake. If it's TPN, it means that it is used exclusively for their nutrition. And that might be in place when, if they have an intestinal obstruction, if their intestines are failing to absorb, if they're on bowel rest, they might receive nutrition TPN. When they're getting nutrition intravenously, it would be kind of a solution of important nutrients like sugars and proteins. Sometimes they add fat or electrolytes, vitamins. Sometimes there's insulin in the nutrition depending on the specific patient need. So it's important to kind of have the language of that sorted out so you know what you're reading when you're looking at the chart review. Okay, so I hope that served as just kind of a dusting off of cobwebs and at the same time thinking about the chart review really through the lens of the cardiopulmonary patient. In our next lecture, we will pick up the discussion of the clinical lab data. Take care.